Hello and welcome everyone to Functional Shoulder Anatomy webinar. My name is Taylor Bennett and I'll be presenting on the topic I just spoke about. So I just wanted to welcome you, a little Fresh Prince, get the mood started, have a little good time, and keep it light in here. I'm excited for everybody to be here and to get some learning. So hopefully we can get going along here. A couple things before we get going. I just wanted to kind of set the scene, so to speak, for this webinar, this webcast. So I'll just pull up this document here, and this is just kind of going to be the flow of the webcast, and we'll just kind of go over everything. So again, we welcomed you. Here in just a short minute, we're going to do an entry poll. So I'm just going to be trying to identify your familiarity with functional shoulder anatomy. Shortly, we will be going over the chat feature, the notes feature, which kind of acts like the whiteboard. Anybody can post notes on there for the entire class to see. And then we'll go over the mood, so that if you would like to raise your hand, if you have a question, your microphones will be muted at the moment. But if you were to have a question, I can unmute you and we can definitely discuss it, or you can feel free to post your questions in either the whiteboard or notes section, or even in the chat section. In the chat section, you can also direct your queries to me rather than the entire class if you feel more comfortable doing it that way. That's definitely available for you to do. So then we're going to go over the PowerPoint presentation. I've included notes for you, so it's kind of the script that I'm using with a little more detail than the PowerPoint itself. I didn't want to put too much wording in, so that it would be a little easier to read, a little more easier to interpret, and it would have a little bit more flow. We're going to have a couple different polls throughout, depending on the different sections of the PowerPoint, and then we'll take a quick little venture outside of the PowerPoint to a link. It's an interactive shoulder anatomy link that we can see the different shoulder structures in 3D rather than in a two-dimensional space like you see on most diagrams. And then we're going to have a little bit of fun with a real quick activity, just to kind of break up the session a little bit and have a little fun with that. And then we'll get into questions. Any questions that you have, feel free to send my way, like I said, through either the chat section or even the notes section. We'll get into that, and then following any questions that you would have about the presentation at hand, you might even save a few of those for our breakout session, where it's going to be real simple. It's divided into groups depending on how many students or how many attendees there are tonight. We can have groups of 3, and each of you will just simply think of 3 things that interested you about the presentation, any facts, aha moments, or even any questions that you might have, and then you'll write those on the notes section with a heading of Group 1 and your name. Okay, so that way I can interpret as to whose questions they are and what group you belong to, and I'll go ahead and unmute your mics during that portion, and we'll have ourselves a little open discussion, and then we'll move to the next group. And the groups in waiting, it'll be really, the breakout session for each group will be about 5 minutes. We're just going to have a little chat and talk about a few things, any things that you found interesting, and the other groups will go to a YouTube link that I provided in a few of the different documents, and you can then go ahead and look at the different ranges of motion of the shoulder. And it's kind of a lengthy section. I didn't want to necessarily do it right in the middle of the presentation because it might get a little bit boring, but the shoulder definitely has a lot of range of motion, and it's good to see examples of that, and you'll also be able to kind of interact a little bit and try those out yourself while you're in waiting. So we'll go ahead and get started here. I'll have a little bit of technical difficulty. Oh, Oh, looks like my internet connection was the. So I'm reconnecting right now, and we'll get right back at it. There we are. Perfect. Okay. So real quick, I forgot to put this part in here. I'm going to go ahead and open my notes section. And I'm going to include the different links that we're going to be using so that it's a little more readily available for us to access. So there's one. And here's the second one, which is a YouTube link. Practice is everything. Alright. There we go. So I'm just going to go ahead and take you through the little features that we have here so you get familiar with them, and we'll get rolling. Perfect. Okay, so the first thing we have is the chat window here, and you have the options to send it to the entire class. You can just send it to me. Anything you want to chat, send my way. Feel free to just send it to me if you're more comfortable that way. Otherwise, if you want to just, I encourage you to post your questions or any comments you have to everyone, so maybe somebody has a similar question or idea. That way we can kind of connect and see where everybody's at there. So I'm just going to say hello class, and can you hear me? Okay, and if you could hear me, you would go up here to my moods and you would give me the thumbs up. Boom, there we go, we got the thumbs up. As we're going along, I'll just kind of get a quick, is everybody doing okay? You can click on fine, which really won't come up with anything. You can click yes, which ultimately is a little easier for me to see. I can say no. If you have a question, feel free to ask it in the different formats. Preferably we'll go with the chat just because it's a little bit easier to do so. Or you can just raise your hand, and if you would like to voice your question, I can unmute your mic and we'll discuss it further. Okay, if you feel like I'm going too fast, you can tell me to slow down, or even if I'm going too slow, you can tell me to speed up. You won't hurt my feelings at all. Sometimes I get a little deliberate in these things, so feel free to give me a nice good push there. Okay, so I'm fine right now. There's that. Okay, now I will have the meeting notes open from time to time. Pretty much we're just going to use this for the breakout session, but feel free to open that yourself, and if you want to put any notes in there, then that's perfectly acceptable as well. So I'm going to go ahead and pull up the PowerPoint presentation, and I've emailed each of you all the different documents, including the participation guide, so that as we go along you have those at reference rather than just have to wait for me to open them. So away we go. We'll get this PowerPoint going. Okay, now before we get going too far, I'm going to go ahead and open this poll. I just want to get a general sense as to how you feel in terms of your current knowledge of shoulder anatomy. So let's start voting here. Okay, if you feel excellent, like you have a really good understanding, click excellent. If you feel like you're kind of in the middle, you know about the shoulder, but there's more that you would like to know, you can click fair, or maybe you haven't had a whole lot of experience with the shoulder, or it's kind of perplexing, and initially when I first started with the shoulder, it kind of was that way, so feel free to click whichever you would like. Okay, I'm going to click excellent. That's just how I'm feeling right now. Okay, so we'll submit that. Okay, looks like we're rolling here. Perfect. So we're going to stop the poll, and we're going to get right into this presentation here. So functional shoulder anatomy, and this is more so based on athletic injuries, what we see in sports medicine, structures, and specific anatomy that is a little more commonly utilized, or you might say evaluated in our setting, rather than the entire thing, So it's a little more pared down for what you need to know. So here we go. So the shoulder is technically called the glenohumeral joint. This means that it is formed by the humerus, hence the humeral portion, and the gleno, meaning glenoid, which is the socket, or the facet of the scapula, the shoulder blade. So this joint here, as you see, is a ball and socket joint. It's a very shallow one, but that shallow socket really allows for a lot of range of motion, and we'll get into the range of motion shortly here in just a little bit. There's a lot of muscular connections to this. There's not a whole lot of ligamentous connections, and again, that allows for free motion of the joint. It allows us to use our arms in the ways that we do. So this joint moves in all three planes of motion: the frontal, the sagittal, pardon me, and the transverse planes. Okay. So we have GH, joint motion. Again, remember, GH stands for glenohumeral. That is the technical term in which we will start to use rather than just the shoulder. Okay, so we have flexion, extension, we have hyper extension, we have abduction, adduction, circumduction. Some people call it lateral rotation. The majority, most people will call it external rotation. And medial rotation, meaning towards the midline, is internal rotation more commonly. There's horizontal abduction, horizontal adduction, and scaption, which is a whole separate deal. We'll get into that. And we also have this video link, which if you go on your PowerPoint, you can copy that. Go ahead and pull that up in your web app whenever you're ready, preferably during the breakout session if you're in group 2 or 3. And you'll go ahead and just look at that, see it gives a good kind of interactive view of the shoulder and its planes of motion. Okay, so we have bony landmarks. I like to address the shoulder in terms of first the bony landmarks, which are the deepest structures, followed by the ligamentous or soft tissue structures, and then we get into the muscular, and that is the most superficial. So here on this picture, we have all the different landmarks labeled dependent on the plane in which you're viewing. So over here, this is the anterior view. If you're looking at the front side of somebody's body, this is how the scapula would look. Okay, we have the body of the scapula here. We have the coracoid process. We have the acromion process, the superior angle, the inferior angle, the medial border, okay, the lateral border, and the glenoid cavity, which is what forms the shoulder joint itself. Now, the majority of these processes, these bony prominences, act as attachment points for muscles, and that's really important to note as we get along into the rotator cuff as well as the scapular stabilizers. This is a lateral view. You can kind of see how the scapula looks. It's a really oddly shaped bone, but it functions very well for, it serves its purpose more or less, okay? So this is the posterior view. If you were looking at the backside of somebody at their shoulder blade, in which you would normally, that's how you would see it. We have the spine of the scapula, which is the big bony ridge in which you were to palpate somebody's scapula. You'll feel that first, followed by the medial border, again the lateral border, and you see these little indentations in the scapula itself, and these serve as kind of grooves for muscles to sit in. Right here, this is the subscapular fossa. This is the anterior view again. This is where the subscapularis muscle sits at, and this is right on the front, actually almost by the rib cage. And on the posterior side, where the majority of the rotator cuff muscles are, besides the subscapularis, you have the supraspinous fossa and you have the infraspinous fossa. Okay, inside this groove here sits the supraspinatus muscle, which comes along in this general way, comes up underneath the acromion process and attaches to the humerus. And then you have the infraspinatus, which then sits in this little concavity here and then comes up, and the tendon attaches a little lower than where the supraspinatus tendon attaches. Okay, so we'll get going to the next slide, which is bony landmarks of the humerus. Now I went ahead and put a dotted line here in the mid shaft of the humerus, just because this is strictly what we're dealing with today in further classes in different forms of evaluation. The lower shaft deals more so with the elbow. So we're talking about the shoulder, so we're going on the superior portion. These other dotted lines refer to the specific necks of the humerus, and this horizontal line is the surgical neck, in which if there's a surgical procedure, this is what surgeons refer to as the neck, whereas this diagonal line is the anatomical neck, the true neck of the humerus, where it attaches, where the ball originates from. Okay, so you have the head of the humerus, which articulates with the scapula to form, that's right, the glenohumeral joint, as we've learned. Okay, and this is just covered with real smooth cartilage, and it allows for frictionless motion in the shoulder joint, and allows for really smooth motion as well, and that's really important. So we have the posterior view. Again, if you're looking at the backside of somebody, this would be the backside of their humerus there, and that is the left. Okay, again, this would be a left humerus. And so we have the greater tubercle, which is a major prominence, the big bump that you feel if you were to palpate somebody's shoulder, somebody's humerus, and that's where a lot of muscles like to attach. And on the anterior side, we have the lesser tubercle, which still is another location for muscular attachments and ligamentous attachments. The intertubercular groove is actually also referred to as the bicipital groove, where the biceps tendon runs through and attaches to the glenoid labrum, which we will talk about shortly. Okay, and then we have the deltoid tuberosity, and you can imagine, the big bulging muscles on the lateral side of somebody's shoulder are the deltoids, and this is where they insert, this is where they attach and finish at. So that's kind of makes sense there. Okay, so we're going to get into the fiber structures of the shoulder, and there's a whole lot of them. I try not to be too detailed because ultimately, as long as you know whether it's the scapulo-clavicular ligaments or the acromioclavicular ligament or the joint capsule, really that's all you need to know. The joint capsule is comprised of a lot of different ligaments, but ultimately they all form one thing, and that's the joint capsule. So don't make it too difficult. That's my rule of thumb. Keep it simple, and just know that this is the joint capsule here. So we have the scapulo-clavicular ligaments, which, as you can see in the name, are based on the scapula, okay, the scapula here, and the clavicle, the clavicular, right? So they originate on the scapula via the coracoid process and attach to the clavicle, and that kind of keeps the clavicle itself pinned down. It keeps it from popping up. And if you've ever seen somebody separate their shoulder or break their clavicle, you'll see the clavicle shoot right up, and that's because they've torn these ligaments here. Okay, and there are actually two ligaments that form the scapulo-clavicular ligament, and that is the trapezoid ligament right here and the conoid ligament, but most oftenly referred to as the scapulo-clavicular ligament. Okay, and then we have the joint capsule itself, and the joint capsule is a really tightly wound fibrous complex and of different ligaments that really acts to hold the head of the humerus in the glenoid fossa. That's its primary component, and so really a lot of indifferent injuries that can be stressed or even torn, but for the specific purpose of anatomy, as it stands today, this is the joint capsule itself. Okay, another important structure to note is the AC ligament, the acromioclavicular, meaning it originates on the acromial process of the scapula and attaches to the clavicle. And this is where the term separated shoulder comes into play. If somebody separates their shoulder, they tear this ligament here, and then the scapula will tend to move upwards because there's nothing holding it down. Okay, so we're going to go on to the glenoid labrum, and this is a very important structure. It provides a little bit more surface area for the head of the humerus to articulate, and it also kind of forms a cup, almost like a suction cup for the head of the humerus. It sucks that head of the humerus right into the glenoid fossa and really makes for a deeper socket because the glenoid fossa itself is very, very shallow. It's almost flat. So a little deeper provides a little more stability, as you see right here. Okay, and on the outside of the ring here, you can see in the illustration the joint capsule is cut. But technically, we would have the humerus inserted here, surrounded by this big fibrous capsule around it. Okay, so we're going to move on to the next slide, and we have the shoulder bursa. The bursa itself is really just a fluid-filled sac. It acts to decrease friction and allow tendons to move freely around bony prominences. That's usually where areas of friction tend to occur the most. And like I said, they're located near tendons where muscles tend to attach or originate. So if you were to have a tendon rubbing over a big pointy piece of bone, it creates friction and it can damage that structure. So these bursa are here to really just kind of cushion that area and decrease friction. So the most commonly referred to bursa would be the subacromial bursa, in that it is the one that we deal with the most in the sports medicine community because there's not much room in the subacromial arch right here, which is the arch that is underneath the acromion process, and there's a tendon that runs right through here. So if this bursa were to be inflamed, it then pushes on the tendon, and it really decreases the amount of space for that tendon to move. Also, we have the deltoid bursa right here, and that sits right underneath the deltoid so that those muscles don't rub on the greater tubercle. Okay, so that's as far as we're really going to get into it. A lot more of this will come in the evaluation process, but as we know, you students, you sports med students, you have a fairly decent anatomical knowledge, so we're just trying to refresh you just a little bit here. Okay, so these next couple of slides are the most important ones because this is what you're going to deal with primarily as an athletic trainer or sports medicine professional. These muscles of the shoulder are the ones most frequently injured, and they're the most dynamic in stabilizing the shoulder. So we have the rotator cuff muscles, and if you don't remember anything at all from this presentation, if you remember one thing specifically, I would recommend that it be the rotator cuff muscles themselves. Okay, so like I said, they act to stabilize the humeral head in the glenoid fossa, and in overhead sports, especially like baseball, softball, javelin throwing, tennis, these muscles act to, one, rotate the humerus, and also to decrease or decelerate the humerus as it comes across the body, so that the shoulder doesn't just pop out of the socket. Otherwise, it would just come right out, and then what fun would overhead sports be, right? So on the posterior side, as you see over here on the right-hand side of this picture, we have the supraspinatus, and we talked about that earlier, sitting right there in the supraspinous fossa. It comes over, and the tendon runs right underneath the acromion process and attaches to the greater tubercle. Just inferior to that, we have the infraspinatus, which sits in the infraspinous fossa, as we again talked about, runs right over here and attaches a little lower on the greater tubercle. And then thirdly, on the posterior side, we have the teres minor, and that comes and attaches even more inferiorly on the greater tubercle of the humerus. Okay, on the anterior side, we have the subscapularis, and this attaches to the lesser tubercle. So these three muscles, the supraspinatus, infraspinatus, and teres minor, they act to externally rotate the humerus, and the subscapularis acts to internally rotate the humerus. So I like to think of it in terms of posterior side externally rotates and anterior side internally rotates, meaning that the arm comes towards the body, and external rotation, the arm goes away from the body in rotation. Okay, and then we have the scapular stabilizers. Okay, and these also are very big because the scapula itself is just kind of a floating bone. The only thing that connects it to the skeleton is the clavicle, so that's really important. So being that it's floating and it's not attached to the skeleton by a whole ton of ligaments, it's not really stable and it's constantly moving, which is what we need to be able to move our arms the way we do, but it also provides a lot of potential for instability. So we have to have these muscles to really hold it in place. And so we have the levator scapulae, okay, which attaches on the superior angle, the medial side of the superior angle of the scapula and attaches to the base of the occipital. And as you can tell by the name levator, it elevates the scapula, so it would bring it upwards. We have the trapezius, and in terms of scapular stabilizers, the middle and lower portion act to retract, bringing the medial border towards the spine, and upwardly rotate the scapula. Okay, these are really big, powerful muscles, and the upper trap really is not involved so much in scapular stabilization. Now, just below that, actually deeper than that, we have the rhomboids. We have rhomboid major, which is inferior to rhomboid minor. These attach on the spinous processes of the thoracic and seventh cervical vertebrae and attach the medial border, and they also act to retract and to downwardly rotate the scapula. So after that, which you don't see, is the pectoralis minor, which is on the anterior side. It attaches to the coracoid process, that kind of pokey prominence you see on the anterior side of the scapula, which we just discussed. And then it attaches to the third, fourth, and fifth ribs, and it acts to retract or protract the scapula and also to elevate the scapula. Then we have the serratus anterior, which if you were to see somebody that has a lot of muscle definition, you see kind of a lot of times they're referred to as the fingers on the ribs. That is that muscle, and it runs along the outer surfaces of the ribs and attaches to the medial border of the scapula and protracts, meaning that it pushes the medial border backwards, so kind of makes the scapula do sort of a chicken wing motion. Okay, so real quick, I'm going to minimize this. We're going to do a quick poll, test your knowledge, see in the short time what you might have just been able to remember in the short term, and we're going to talk about the rotator cuff and scapular stabilizers. Okay. Okay, so I'm going to go ahead and pull this poll up, and you feel free to go ahead and vote. So what muscles comprise the rotator cuff? The supraspinatus, the infraspinatus, the teres minor, the subscapularis, or all of the above? I'm going to go with all of the above because that's always a good answer, right? Yeah, sure. And I'm going to go ahead and tell you that that is the correct answer. Hey, I need the poll. Somehow I knew the answer. Pretty cool. So we're going to stop voting here, and we're going to go on to we're going to go ahead and keep rolling here. We're going to take a quick break, actually. I wanted to go ahead and kind of just pause on the muscular stuff, and we're going to go ahead and come out this way. I'm going to open my notes so I can copy this link, and we're going to go ahead and check out a 3D model of the bony and ligamentous structures of the shoulder. Let's go here. And away we go. So I'm just going to play around with this real quick, but I wanted you guys to see this. That way you can visualize what these structures look like, where they're located in a three-dimensional space, and then you can go ahead and feel free at any point to go ahead and mess around with this. Maybe even when this webinar is done. You can go in here and kind of play around and listen. You can also come up here and change the view angle so you can look at the shoulder from the posterior side. Very important also to see. Let me just go over that and click there. And it'll pop up shortly. There we go. So now you can see the spine and scapula, the scapula itself. We got the clavicle, we got the bursa, and the humerus, and you can kind of just go, and these are just general major structures. Okay, so there's that. Feel free to go ahead and play around with that. Even when we do the breakout sessions, group 2 and 3, while you're waiting, you can go ahead and play with that, as well as look at the YouTube video. We're going to come back over to this presentation. Okay, so we're just about done with the PowerPoint itself. We'll talk about the auxiliary muscles of the shoulder based on the side in which they're located, and then we're just about done. So we'll be breaking into this breakout session very shortly, and just feel free again to let me know if we're moving too fast. I kind of tend to speed through this a little bit, so just slow me down if you need to. So on the anterior side, and what I mean by auxiliary muscles of the shoulder, they're not necessarily the prime movers or the stabilizers. And what we're concerned about in the shoulder in terms of injury is the stabilizers, the stabilizing structures, the soft tissue like the ligamentous structures, the labrum, and the rotator cuff and scapular stabilizers. The rest of these muscles, they actually act upon the scapula to move it in specific components, but they're not necessarily injured in relation to shoulder movement as much. So just feel free to take a look at these that are listed here. We got the coracobrachialis, triceps brachii, biceps brachii. Everybody loves a good biceps, right? And the pec major. So these guys minus the coracobrachialis, this helps with the beach body, right? Yes, yes, indeed. And then on the posterior side, we have the trapezius. Auxiliary wise, the upper trapezius is an auxiliary muscle, even though it is still all the same muscle. Okay, it is the upper section. You got the deltoids, again, helps with the beach body. Teres major, which acts to internally rotate. It's not necessarily a scapular stabilizer, more so just a rotator. And then the latissimus dorsi, the big wings. You know, you see the guys walking around and walking around the beach with their arms all puffed out and such. And that's the lat that they probably got some big ones rolling. Again, beach body. It's getting close to beach season, guys, so just know these muscles, okay? Just a little joke, taking it easy. Okay, so go ahead and feel free to post any questions you have over here in the chat. I'm going to just type that in the questions. Okay. Maybe it'll post any questions. And then we're going to go ahead and break into the breakout sessions. All right, so we have group 1, which you guys know who you are. I've indicated you prior to this session, and I just want you to think of 3 things that you gather from this presentation. So we have interesting facts, aha moments. I know I certainly like aha moments, and any questions that you might have. And so think about those for just a short minute and go ahead and write those down over here on the notes section. Everybody can see this, so just go ahead and title it group 1 and your name so that I know what belongs to who. And I'm going to go over here and I'll say this is me. Unmute your mic, and when you're ready, go ahead and just say ready, or you can come over to the moods and say, give me a thumbs up when you're ready to go, and I'll call on you. You can tell me what 3 things you came up with, and we'll discuss that. And groups 2 and 3, go ahead and go to this link over here and take a look at the video. Go ahead and keep your mics muted so that we don't have all the echoing from the video itself. And then once we're done, I'm going to come over this way and I'm going to put the hands up. Okay, so just give me about 5 minutes. We'll go hands up. When you come back and you're ready to go and have thought about those questions or aha moments, etc., go and give me the thumbs up and I'll know you're ready. Alright, so just be patient real quick and we'll get rolling shortly. So hopefully you guys gained something out of this presentation, and let me know if I can answer any of your questions otherwise. So from here on out, I'm going to go ahead and close this. Alright guys, thanks for participating.